Assalamu alaikum. This is the presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is pure tone audiometry or PTA part 2. So the objectives of this presentation is that at the end of this presentation the student should be able to recognize the audiogram and its patterns in different ear diseases, able to interpret the audiogram, able to create diagnosis in certain cases or even differential diagnosis according to the given audiogram, identify the type and degree of hearing loss. These are the two most important things to find out in an audiogram. So this is the repetition from the first part. This is the sample of an audiogram. As we have already discussed that the frequency is on x-axis and decibel hearing level or intensity is on y-axis. So basically how you start the procedure in the room. When examiner start the procedure, he can either go from below upwards or he can come from above downwards. He will give the sound, the pure tones through the machine, and whenever the patient hear the sound, he will press the button and that frequency at that particular intensity will be bypassed, as that was normal for that patient. For example, how we start? We start from 500, then go to 1000, 2000, 4000, 8000, then 250, and in the end again recheck the 500. So the difference can be of 10 decibel, but the minimum difference is not below 5 decibel. I mean, you cannot give the sound difference of less than 5 decibel. So in the start, if you are starting from 120, so 10-10 gap is given, 120, then 110, 100, 90, 80, 70, 60, when the patient is pressing the button. And let's suppose at 50 the patient did not press, but on 60 he presses the button. Then again check the 60, he presses the button. Now the gap will be of 5 decibel. Now the at 55 decibel intensity the sound will be given, and if patient press the button, then again check for 50 decibel. If he didn't, or if he don't press the button, then again check the 55 and he pressed the button, then 55 decibel is his minimum threshold level at 500 hertz. Repeat and do the same for 1000, 2000, 4000, 8000, 250, and again 500. Recheck it, and in this way a graph is formed. So these are the frequencies, different frequencies at which air conduction and bone conductions are checked, and these are the three speech frequencies, the mean of which is taken. We will see in the graphs, coming graphs. These are again the symbols for right and left ear. And these are the degree of hearing loss, same like in this chart. I have all discussed this in my part 1. So this chart, for conductive deafness, the air conduction will be worsened or bad, while the bone conduction will be normal, and the ear bone gap will be 15 decibel or more. For sensorineural deafness, both air conduction and bone conduction will be worsened or bad, and air bone gap is less than 15 decibel. While for mixed, both air conduction and bone conduction will be worsened, so which is the element of sensorineural hearing loss, and air bone gap of 15 decibel or more is present, which is the feature of conductive hearing loss. So in mixed, both features of sensorineural and conductive will be present. So now coming to the graphs. So first we will see, as I already mentioned, up till 20 decibel, whatever graph line is fall, it will be normal. So if air conduction graph, as it is circle, so this is of the right ear. If air conduction graph is above 20, then either you do the bone conduction or you don't do the bone conduction, it doesn't matter at all. So this will be a normal audiogram. Now coming to the second audiogram, again this is of the right side, the circle is showing. So if we look at uh, this audiogram, the minimum gap between any frequency is more than 15 decibel. So airborne gap is present and bone conduction is above 20 while the air conduction is below 20. So this means that this is a graph of conductive hearing loss. To be precise, we have to take the mean of these three speech frequencies for both air conduction, which will be 30, 35 and 30. So 95 divided by 3 is around 31. 31 to 32, and the bone conduction of these three frequencies is 3.3. So the airborne gap is 28, which is more than 15 decibel. And since the air conduction is 31, which is in moderate mild hearing loss level, so the degree of hearing loss in this will be mild. So the patient will have conductive hearing loss of mild degree. This graph, when placed, the question can be asked, write differential diagnosis, 8 differential diagnosis for conductive hearing loss, or it will not be written conductive hearing loss. The question may be there, write 8 or 6 or whatever number of differential diagnosis for this type of graph. Okay, so you have to be sure what graph is there so you can write the exact causes. Secondly, just mentioning if the question is there that what are the findings in this graph. So just writing conductive hearing loss will not give you full marks because you have to justify why you have written conductive hearing loss. So these two things, that the air conduction graph is below 20, bone conduction graph is above 20 and AB gap is more than 15 decibel will be justifiable, and you will, after writing this and then you write its conductive hearing loss. So it can be impacted wax, foreign body, external aortic canal, stenosis, polyp in external aortic canal, chronic suppurative otitis media with effusion, acute suppurative otitis media, autosclerosis, ossicular discontinuity. So there are many causes for conductive hearing loss. Okay, this is another graph. Again, if we see the air conduction graph is below 20. Now it is crossed, so this is of left side. So air conduction graph, it is below 20 while the bone conduction graph is above 20. And if we see the minimum gap on the two closed portion of the graph, it is again more than 15 decibel. So this is rough estimation. Uh, to get the proper estimation, you have to take the mean of these three, which will be 41, 47, the mean of these three, and the mean of these three will be 12. So again, the gap is around 35 decibel, which is more than 15 decibel. So this will be conductive hearing loss. But there is an other finding in this graph as well. Okay. So that finding is, if you see closely, there is a small dip at 2000 hertz. So there is a dip in bone conduction at 2000 hertz, which is known as Carhart's notch. So this typical graph or audiogram is present in a single disease. So whenever any specific graph for a specific disease is present, then the question will be according to that disease. So you may be asked what is the most likely. First question is what are the findings in the graph. So you have to explain both about these findings. And remember that you don't have to write dip at 2000 hertz. You have to write dip in bone conduction at 2000 hertz. Then it will be correct. So what will be the diagnosis? It will be autosclerosis. So read the question properly. Have they asked about the diagnosis? Have they asked about the findings? Have they just asked about the treatment? I mean, you have to clear about what question you have been asked. Now coming to the next graph, if we look at this graph, so both air and bone conduction graphs are below 20. So this is in blue and cross. So this will be of the left ear. and both air and bone conduction graph are below 20. Secondly, the gap is less than 15 decibel. You don't have to write that there is no gap. You just write the gap is below less than 15 decibel. So this will be both air conduction and bone conduction below 20 decibel. Both are worsened if you remember the previous table which I have shown. And it means that it will be sensorineural hearing loss, and as it lies above 20, so it will be mild degree of sensorineural hearing loss. Another graph of similar type, but there is little difference in this, which I will tell you. So if we see up till 20 decibel till 2000 hertz, both graphs lie above 20, which are in normal range. But after that, both graphs are below 20. So it means that sensorineural hearing loss is about to start, or has been started. So there is high frequency sensorineural hearing loss, but this patient's hearing level will be normal, because as I already mentioned, in speech frequencies there is no hearing loss. So the patient will present to you with complaint that if somebody is speaking from far, I am not able to hear that, but in my normal conversation there is no problem. So this is very important, because there will be no as such hearing loss, but the hearing loss is started, and the nerves, they are started to get damaged. It can be present in age-related hearing loss, ototoxicity, noise-induced, or any other causes. Uh, so that can be there. So worse in high frequencies, but in speech frequencies it is normal. Such graphs, this one or the previous one or the coming graphs, two types of questions can be asked. If there is any specific graph that is present in a single disease, then question will be related to that disease. Or if there is no specific graph like this one, you can be asked to write 4 differential diagnoses of this type of graph. So this graph, as we know that of sensorineural hearing loss, so it can be age related, which is presbycusis, acoustic neuroma, ototoxicity, sudden sensorineural hearing loss, noise induced hearing loss, Meniere's disease. So you can write any of these. So again, another type of graph in which both air and bone conduction are below 20 and the gap is less than 15 decibels. So this is again a graph of sensorineural hearing loss, and the differentials which I have mentioned are the same for this type of graph as well. Okay, now there is another graph. If you look closely, both air and bone conduction lies below 20 decibel. So and the gap between them is less than 15 decibel. So this is a graph of sensorineural hearing loss. But if you look closely, both AC and BC below 20 and worse. So it is moderate. If you take the mean of these three, so it will lies around 40, 40 to above 40, 41, 42. So it's moderate degree. But there is another finding in this graph. There is a dip at 4000 hertz. This dip is specific for one disease. Okay, so what will be the diagnosis for this type of graph? It will be noise induced hearing loss. So this dip is present in noise induced hearing loss. Uh, Again, remember that if patients they present late, even with noise induced hearing loss, you may not able to find any dip here, or the gap may be widened in that, and then it will become flat first and then down slope. So another graph, again if we look at 2000 hertz, there is normal, but then there is a sudden drop at 4000 hertz with a dip. So this dip again, as I mentioned, is in the noise induced hearing loss. Uh, so this is a graph of noise induced hearing loss, but patient's ability to conversate and hear will not be affected till this stage, at this stage. But if he continues to stay where there is exposure to noise, then he may develop further deterioration of his hearing. Okay, there is another graph, a little different type of graph. What is the difference? First, if we see the type, both air conduction and bone conduction, they are below 20 decibel. So this is sensorineural hearing loss. If you remember the previous graphs, all they are affected in high frequency first, but this typical graph is affected in lower frequencies first. So this is a moderate degree of sensorineural hearing loss, and lower frequencies are affected first. So this is present in one specific disease. So what is the diagnosis? It is Meniere's disease. So again, this is the same. Lower frequencies are affected with both air and bone conductions below 20 and gap less than 15 decibel. So this is again of Meniere's disease graph. But one important question is lies why Meniere's disease it affects the lower frequencies first. So the question lies in this diagram. If you look at the cochlea, the apex part, it is concerned with the lower frequencies and base is concerned with the higher frequencies. So in Meniere's disease, the apex is affected first and then it will proceed and go forward. So that's why the patient will present with lower frequency hearing loss initially, and then if we look in these graphs, so these are the different stages of Meniere's disease. First, there will be the uprising, that lower frequencies are affected, higher frequencies are spared. If disease is progressing, then patient may present at this stage where there will be a flat drop. Or maybe if patient present late, the stage may be that there will be downsloping, as I have showed you the previous sensorineural hearing loss graphs. There is another graph. If we look, the left side it's normal, but the right side it's diseased with both air conduction and bone conduction graphs below 20. But if you look closely, the bone conduction, air conduction is masked. So I have told you in my previous part 1 lecture that masking in air conduction is carried out if the difference between the air conduction of two sides is more than 40 decibel. So here the difference is more than 40 decibel, that's why the right ear is masked. So this again is uprising type, so the diagnosis may be Meniere's disease if single diagnosis, and if differential diagnosis, then any other condition can come. But two most important, if this graph is like this or downsloping, then the most likely diagnosis is not Meniere's, then it will be acoustic neuroma. Acoustic neuroma is the most likely or most common diagnosis of unilateral sensorineural hearing loss. Though Meniere's disease is also common unilaterally, but it is in around 60-65%, whereas acoustic neuroma is unilateral in 90% of the cases. So this question is also there, a patient with unilateral sensorineural hearing loss with tinnitus. The most likely diagnosis is Meniere's disease, acoustic neuroma, and the next investigation is MRI. So if this patient with this straight graph and none other symptom of Meniere's disease, then we may have to proceed with uh, MRI to rule out the acoustic neuroma. So this another masking air conduction, but the gap is more than 15 decibels. So this is on one side of conductive hearing loss, and the left side is normal. Okay, so there is another graph. If we look closely, there is no response, which is shown by the downward arrows on the right side in air conduction and in bone conduction on left side. So the patient's hearing is absent when they are not able to hear any sound via the air conduction headphones or the bone vibrator. Then you have to label it with downward, showing that there is no response. This is the graph in which if you look, the right side is normal, but for the left side both air conduction and bone conduction graphs are below 20. You see, it's below 20, but the air-bone gap is more than 15 decibel. So this is the mixed hearing loss, and I have shown the causes in my part 1 presentation. So this, when both graphs are below 20, both are worse, but the gap is more than 15 decibel, then it is mixed hearing loss. So in the end, the last slide is the advantages and limitations. So it's a very simple, reliable and widely available test, and helps in diagnosis and treatment planning and prescription of hearing aid. While there are certain limitations, as this test requires patient cooperation and patient dependent. So if patient response is not proper, then the result might not be fully correct. And secondly, this test is not suitable for infants or uncooperative patients. As it is in a closed soundproof room or booth, some patients, they have phobia of sitting in there, so they cannot go undergo this type of test properly. And in infants, we perform other tests like BERA or ASSR while making them sleep, because small children, infants and small children, usually after 7 or 8 years this test can be performed, or if child is very active and understandable, then after 5 years you can perform the test. And also in children, sometimes what we do, you have to give a trial first day of the test, and then you have to repeat the test in children, small children, after 1 week, so they get better used to or understand better, and give proper response next time. But for small children, you have to perform BERA or ASSR. So this is all about the pure tone audiometry and audiograms and its graphs. In 2 parts I have prepared this. So thank you.